Hello, everyone, and welcome to our module on ST elevation myocardial infarction. So an ST elevation myocardial infarction is a form of myocardial infarction associated with ST elevations on the EKG, and we'll see some examples of this in a minute. And this condition is often called STEMI for short. And by way of review of some things that I talk about in the cardiac ischemia video, STEMI is associated with rupture of an atherosclerotic plaque and formation of a thrombus on top of the rupture. So this is a cartoon depiction of what it looks like here on the screen. This is a coronary artery. We've got a lipid-laden plaque that's ruptured and a thrombus has formed on top of the plaque. Now, what makes STEMI unique and different from NSTEMI and unstable angina, which are also conditions associated with plaque rupture and thrombus formation, is that only in STEMI do you have complete 100% vessel occlusion. So you can see that in the cartoon here. None of these red cells can get beyond the occlusion. The artery is completely occluded, and that's unique to STEMI. Patients who develop this condition develop chest pain, usually at rest, and their biomarkers will be elevated on blood testing, things like troponin and CKMB. And then finally, as I mentioned, there will be ST elevations on the EKG. And now some more review of some of the concepts I talked about in the cardiac ischemia videos. So as I said, in STEMI, there's complete occlusion of a coronary artery, and that leads to transmural ischemia, meaning ischemia involving an entire wall of the left ventricle. So if you look at this cartoon right here, this is the left ventricle here, this is the right ventricle, and this purple area is the anterior wall. And notice that it represents ischemia involving the entire wall, not just a portion of the wall. That's called transmural ischemia, and that's what you expect to happen in STEMI. And so I've summarized some of the key findings pathologically to know about STEMI at the bottom of this slide. It involves an ulcerated plaque with thrombus formation, complete occlusion to blood flow, no distal blood flow, and then, as I said, transmural ischemia. Just to help you get a very clear picture in your mind of what's happening inside the vessels of the heart during a STEMI, this is a coronary angiogram from a patient having a right coronary artery STEMI. So this tube you see here is a catheter. It's a plastic tube connected to the wrist, and the dark material you see is dye being injected. And the dye is being injected into the right coronary artery here, but the dye only goes about an inch or so down and then it stops. And the reason it's stopping is because there is a thrombus there. You can't see the thrombus, you can only see the dye, but the dye only goes a little bit down the artery. Now here's that same patient's artery after the thrombus has been removed and a coronary stent has been placed. And so now you can see how enormous the vessel is, but in that last image we saw, the vessel was only about an inch long filled with dye, and that's because the thrombus wasn't letting the dye get down to the end of the blood vessel like you see here. So as I said, the defining feature on EKG of a STEMI is the presence of ST elevations. And depending on which leads show the ST elevations, that can tell you which wall of the left ventricle is ischemic. So for example, when the anterior wall of the left ventricle is ischemic, you will see ST elevations in leads V1 through V4. So you'll see it in V1, V2, V3, and V4 when the anterior wall is ischemic from a STEMI. And here's a picture of an anterior STEMI. So these are ST elevations shown here in lead V2. This is the baseline I'm marking with my pen. Here's the ST segment. You can see it's elevated up in the air. We have ST elevations here in lead V3, also in lead V4, and a little bit even in lead V1. If you want to see what a normal ST segment should look like, look at lead 1 over here. That's pretty normal. But these V leads like V1 through V4 are showing the most significant ST elevation, and that tells you that the anterior wall of the left ventricle is the area that's ischemic. When the lateral wall of the left ventricle is ischemic, you see the most prominent ST elevations in leads V5, V6, 1, and AVL. These are sometimes called the lateral leads. And so here's an EKG from a patient who's having a lateral wall myocardial infarction. Note the ST elevations seen here in lead 1. You can also see them in lead AVL. You can also see them a little bit here in V6 and V5. These are the lateral leads, 1, AVL, V5, and V6, showing ST elevations in a lateral left ventricular wall myocardial infarction. And then finally, when the inferior wall of the left ventricle is ischemic, the leads that show ST elevations are leads 2, 3, and AVF. These are called the inferior leads. And so here's a patient having an inferior wall myocardial infarction. Note the ST elevation in lead V2. It's even easier to see in lead V3. It's also here in lead AVF. These are the inferior leads showing ST elevations in an inferior wall myocardial infarction. Once you know what wall of the left ventricle is ischemic, you can usually determine which vessel has the blood clot in the STEMI. So when the anterior wall of the left ventricle is ischemic, That indicates a thrombus and a lack of blood flow through the left anterior descending artery. So as we said, when you see leads V1 through V4 with ST elevations, that usually indicates that the LAD is going to be the vessel that has the thrombus in it. When the lateral wall is ischemic, that's usually due to the left circumflex artery having a thrombus in it. So remember, leads 1, L, V5, and V6 indicate the lateral wall associated with blood flow from the left circumflex artery. And then finally, when the inferior wall of the left ventricle is ischemic, that means the posterior descending artery is the vessel that has a thrombus in it. So this is leads 2, 3, and F, which indicate the inferior wall. And in about 90% of patients, the posterior descending artery is a branch of the right coronary artery. These patients are called right dominant. In a smaller number of patients, about 10%, the PDA comes off the left circumflex. These patients are called left dominant. So in patients who have a STEMI and develop chest pain, the major complication you worry about is that they can develop an arrhythmia that can lead to cardiac arrest. But beyond that, there are some special complications associated with different types of STEMIs. So let's talk about those now. So first, let's talk about a special complication of an inferior myocardial infarction, and that's a right ventricular infarction. So remember, when we talk about the anterior wall, the lateral wall, and the inferior wall, we're always talking about the left ventricle. The right ventricle is rarely involved in STEMIs, but when it is involved in STEMIs, it's usually from an inferior myocardial infarction. So when this happens, the right ventricle can lose its contractility and lose its function. When you have that happen, the right ventricle is not doing its job and blood backs up into the venous system. So you can see a lot of the findings that are often associated with heart failure, things like elevated jugular venous pressure. In addition, one of the major things the right ventricle does is it provides preload to the left ventricle. So you lose that preload when there's a right ventricular infarction, and so that can lead to hypotension. So in any patient who has an inferior STEMI, remember a STEMI with ST elevations in leads 2, 3, and AVF, if that patient develops hypotension and elevated jugular venous pressure, you have to consider that they may be having right ventricular involvement of their inferior STEMI. And the way you diagnose this is by using right-sided chest leads for the EKG. So shown on this slide are where the leads for obtaining an EKG are normally placed in the patient. So the chest leads are the V leads. They go from V1 to V6. They're called the chest leads because the stickers are placed across the chest like this. And normally lead V1 goes over here, and then V2 through V6 wrap around the patient's left side. In order to obtain right-sided chest leads, you switch these positions and you place chest leads along the right side of the body. And when you do that, if the patient is having a right ventricular infarction, you will see ST elevations in those right-sided chest leads. And that's the way you make a diagnosis of a right ventricular infarction. You suspect it when the patient has an inferior STEMI and they're developing hypotension and elevated jugular venous pressure. You can then confirm the diagnosis by obtaining these right-sided chest leads. Another special complication of inferior MIs is sinus bradycardia and heart block. That's because the inferior wall is very close to the vagus nerve, and for reasons that are incompletely understood, when the inferior wall becomes ischemic, it can actually stimulate the vagus nerve, so there are more vagus signals to the heart. And this can slow the sinus rate, causing sinus bradycardia. It can also cause heart block. This is an example of Mobitz 2 heart block shown here, and that's something you can see in patients having an inferior STEMI. I'll show you EKGs from two very unusual forms of STEMI. This is a STEMI caused by occlusion of the left main coronary artery. Recall that the left main coronary artery is a short coronary vessel that branches into the LAD and left circumflex. So when the left main has a STEMI, you get ischemia involving both the LAD and the circumflex territories. So the classic finding in a left main occlusion is ST elevation in lead AVR. Lead AVR is usually not that important. It's sometimes called the forgotten lead, but one time when it is important is when there's occlusion of the left main. You will see ST elevations in AVR. All the other leads will show ST depressions, and that's what you can see on this EKG. Flip T waves and ST depressions in leads like V6. You can see them in V2. You can see them in 2. You can also see them in 1. All the leads are showing ST depressions except for lead AVR. And then another unique subtype of STEMI is a posterior myocardial infarction. This is where there's a myocardial infarction limited completely to the mid to distal PDA vessel. When this happens, you can sometimes see no inferior ST elevations. Note that on the CKG, there are no inferior ST elevations in leads 2, 3, and AVF. But what you will see is ST depressions and flip T waves in leads V1 through V3, sometimes even out to V4. So what you're seeing here is an absence of ST elevations, but whenever leads V1 through V3 show these deep ST depressions and flip T waves, especially if the patient is having ongoing chest pain at rest, you have to consider that they might have a posterior myocardial infarction. This will not show ST elevations on the typical EKG. If you want to see the ST elevations in this case, you have to do so-called posterior chest leads. So back to this drawing, we talked before about how right-sided chest leads are EKG leads placed on this side of the chest. Well, for posterior chest leads, you put additional leads beyond V6. So you wrap around the patient's back and put a lead like V7 and V8 and V9. And these leads will show ST elevations in a posterior myocardial infarction. You won't see ST elevations in the normal leads. So just to review, these are two special subtypes of STEMI that we've talked about. In a left main STEMI, there's ST elevation in lead AVR, the forgotten lead, and diffuse ST depressions. In a posterior STEMI, you will see anterior ST depressions with the standard leads. By that I mean ST depressions in the anterior leads, like V1 through V4. But then if you obtain posterior leads, which are leads V7 through V9 placed around the back, there is where you will see the ST elevations in a posterior myocardial infarction. Now let's talk about the treatment of STEMI. So you will hear it said when treating STEMI, time is muscle. And by this we mean that a coronary artery is completely occluded by thrombus with no blood flow. So the longer that occlusion persists, the more myocardium that will die. And there have been lots of clinical studies that show the longer a STEMI goes on, the more likely the patient is to die, the more heart failure symptoms the patient may get down the road, and the more future hospitalizations the patient will have for heart disease. So the longer you wait to treat a STEMI, the more this bad stuff tends to occur. And so for this reason, a STEMI is considered a medical emergency. The main objective when you're treating a patient with a STEMI is to get the artery open and restore blood flow to the myocardium. This is called revascularization. And there are two ways this is generally done for the emergent treatment of STEMI. Way number one is an emergency angioplasty. This involves having a cath lab team on call that can come in and perform an angiogram and then insert an angiography balloon and blow up the balloon to smush the thrombus and the plaque against the wall and restore blood flow in the artery. It's basically mechanical opening of the artery. It's a minor surgical procedure. It requires an on-call team. And ideally, this should be done in less than 90 minutes from the time the patient arrives in the emergency room. This is called the door-to-balloon time, and it's monitored for hospitals because it's considered a quality metric if the door-to-balloon time is too long. Now, if emergency angioplasty can't be done, the other option is a thrombolytic drug. This is a process called thrombolysis, and all it requires is an intravenous line so you can inject an intravenous drug. So you can lyse the thrombus with a drug if you don't have angioplasty available. And ideally, that should be done in under 30 minutes. This is also a quality metric. It's called the door-to-needle time. So as I said, when you're treating a STEMI, your main goal is to open the occluded artery, and time matters. So any medical therapy you're going to give is supportive. And by that, I mean it's something you do just to keep the patient from getting worse while you're doing the work to open the artery. So your main goal is an angioplasty or a thrombolytic drug. But while you're waiting to do that, there are medicines we sometimes use as so-called supportive therapy. To understand the medicines we give, remember that this is a thrombotic problem. There's a thrombus in the coronary artery. So often aspirin is given to inhibit platelet aggregation and heparin to inhibit clot formation. The idea here is just to keep the patient's problem from getting worse while you wait to do the definitive therapy of opening the artery. This is also an ischemic problem, so beta blockers are often given because they reduce oxygen demand. Nitrates also reduce oxygen demand, and so these things can take the work off the heart and sometimes make the patient's chest pain better while you're working to open the artery. So a couple of cautions about giving medicines to patients who are having a STEMI. So as I said, we often give beta blockers to patients having a STEMI while we're working to open the occluded artery. But as I said before, with inferior myocardial infarctions, you can get stimulation of the vagus nerve. So these patients can develop bradycardia and AV block. So before you give a beta blocker to anyone with a STEMI, you obviously want to make sure they don't already have bradycardia or AV block from an inferior MI. And then we often give nitrates to patients with STEMI, as I mentioned. But remember what I said, when the right coronary artery is occluded, this can cause an RV infarct. And when there's an RV infarction, this lowers the preload. Nitrates also lower the preload, so this combination can lead to life-threatening hypotension. So in any patient having an inferior myocardial infarction, that's a STEMI involving leads 2, 3, and AVF, these patients are at risk for RV infarct. And so if they have elevated jugular venous pressure or hypotension, especially hypotension after a nitrate, you have to consider they may have an RV infarct. These other drugs shown on the slide here are sometimes given to patients with STEMI. They all have different evidence supporting their use. Some of them are used in some institutions, but not others. So clopidogrel is an ADP receptor blocker. It inhibits platelets. It's sometimes used in STEMI. Same for eptifibatide, which is a 2B3A receptor blocker that inhibits platelets. And then finally, bivalirudin is an intravenous direct thrombin inhibitor. It's sometimes given to inhibit clot formation. So I'll finish with just 2 examples of the typical course of a STEMI patient when they come to an emergency room in the United States. So let's imagine the patient arrives at the ER with chest pain at 5:42. An EKG is done within 10 minutes. That's the standard of care, and the STEMI is identified. If it's a hospital that has a cardiac cath lab team on call and available, they'll be activated for emergency angioplasty. While you're waiting to perform the angioplasty, meds can be given in the ER, like all these drugs shown here, aspirin, the beta blocker metoprolol, a nitro drip, or heparin bolus. And finally, the patient goes to the cath lab at 6:15, about 20 or 30 minutes after they arrived. It takes some time to get the artery opened with a balloon angioplasty, but that occurs at 6:42, and this gives us a door-to-balloon time of 60 minutes. There's 60 minutes from when the patient arrived at the door to the ER to when the balloon was inflated to open the artery, and this is within the ideal framework of less than 90 minutes. An alternative course for a STEMI patient at a hospital without angioplasty available is shown on this slide. So the initial events are the same, but then because angioplasty isn't available, TPA is given. TPA is a thrombolytic drug. It's given based on the patient's weight. And so this is done at 6:07 p.m. as an IV push. And this gives a door-to-needle time of 20 minutes, which is within the ideal range of less than 30 minutes. And then I'll finish with this slide, which is a slide I show in some of the other videos, and it summarizes the different coronary artery disease syndromes. So in this video, we're talking about STEMI, and the key features of STEMI you want to know for step 1 of your boards are all on this slide. So the chest pain in STEMI is almost always at rest, in contrast to other types of coronary disease where the chest pain can be with exertion. There's going to be elevation of the biomarkers like CK and troponin. And then on EKG, you're going to see ST elevations. That's the defining feature. Remember that this causes transmural ischemia in a wall of the left ventricle, and that occurs because you have plaque rupture with clot formation. And then in the artery that's causing the STEMI, there should be 100% occlusion, in contrast to all these other forms of coronary disease syndromes. And that concludes our module on ST elevation myocardial infarction.